You must have gone through the anatomy of the. You must have gone through the anatomy of the larynx, and today actually we are discussing the congenital lesions. As we all know that these congenital lesions will occur in most of the cases in newborns. So there is a slight difference between the anatomy of the larynx of the adults and the children as well. So basically, as we know that larynx, what is the main function of the larynx? Main function of the larynx is main function of the larynx is not only the phonation. This is basically the secondary function of the larynx. The primary function of the larynx is to protect the airway whenever we swallow, whenever we speak. So, this is the most important function. And then later on, definitely, it will help in the respiration and breathing also. But what makes a difference in between the larynx in adults and as well as in the children? So, the basic difference is, as we know that in adults, the larynx, the length of the larynx, it extends from the third cervical vertebra to the sixth cervical vertebra, and it is present in front of the hypopharynx. So is the case in the children also, newborn. That larynx is in front of the hypopharynx, but it is a short. It is the total length is around from. It extends from first cervical vertebra to sports vertebra. And what is the importance of this, shortening of the larynx? The most important, basically, the major effect is, as you know, the neonates are nasal breather. So whenever they feed, during feeding, this larynx, the shortened larynx, this will elevate and then close the air passage. So they can easily, breathe as well as they can feed simultaneously. And this is very important for newborns, infants, kids. So other definitely other differences are the cartilages are very soft, and they can easily bend, and whenever there is any inflammation, any infection and occurs in the larynx of the children, so immediately this inflammation and infection spread, and it will cause different complication. So, and as the patient, as the child grows, then this again larynx will increase. It is again it increases in two different forms of the growth in the larynx. Like first 3 years, the larynx will grow horizontally as well as slightly in its length also. But after 3 years, and this is very important because before 3 years they are wholly solely dependent on the feeding, and they don't have any idea about proper nasal breathing and normal respiration. So as the age grows after 3 years, then the larynx will grow lengthwise. And the important thing is that the vocal cord, the size of the vocal cord, the arytenoid, the area epiglottic fold, the whole size of the larynx would be increased. And this will help in the phonation, and as well as there's a change of the voice later on in the adults. So these are the few differences which is important to know the difference between adults and the children. Now coming to the what are congenital anomalies. So basically congenital anomalies, that these are basically errors during embryogenesis or as a result of intrauterine events that affect embryonic and fetal growth. Of course, these are the congenital lesions. And what effect does it occur? Basically, this will cause defects in formation and growth of larynx, lead to a variety of malformations. So, as we know, these congenital anomalies, they are mostly present in the newborns. So, what are the clinical manifestations? These are very important because they don't tell you, they can't say anything to you. So, the clinical manifestation in neonates is the first presentation would be respiratory obstruction. Yes, there's a stridor, as well as there's sometimes weak cry, dyspneic. As I have already told you, it has a small larynx, and the cartilages are very flaccid and soft, so they can easily get into these complications, and the patient will present tachypneic, aspiration would occur. So mother can see that there's a patient can go into cyanosis, and sometimes sudden death can also occur. So first and the most commonest congenital anomaly is called, which is called laryngomalacia. Again, laryngomalacia. As the name shows, malacia means that a softening of the part, and laryngomalacia means it's softening. The whole larynx and cartilages would be, very softened in the larynx. As these cartilages are very softened, so what would happen? They won't function properly, and they can easily, go get into the complications. So, and this term first time introduced by Jackson and Jackson in 1942. So what are the features? Basically, again, as I have already told, that there's a softness of the laryngeal tissue, there's flabbiness and lack of consistency of the laryngeal tissue. And then what happens? The cartilages, they become thin and hypocellularity. You can easily mold whenever this respiration occurs. The cartilages will change its shape, wrinkled, loose, or redundant mucosa. So what happened then? Again, this is whenever the question comes, what is the commonest cause of the stridor or any congenital anomaly? This is laryngomalacia. So how will you diagnose? So as you can see in these pictures, this is basically larynx. This is epiglottis, and basically how can we diagnose? Flexible endoscopy. Just we use a flexible endoscope and we can visualize these patients. Sometimes before going further, the presentation is very, common in these cases. Whenever the patient comes to you, the presentation would be, a patient, whenever the mother will say that this is a particular sound which he's producing, but the next question the physician should ask, whenever you put your child in a prone position, either it would go or it will remain. The answer would be then she would, and you can also do it in your clinic. When you put the patient in a prone position, the sound would be vanished. So this is again one of the clinical, diagnosis of the laryngomalacia. But how can we go for testing? Now, diagnosis flexible endoscopy. A small child, of course. After getting your clinical diagnosis, we can go for flexible endoscopy, and whenever we do it, we will see that there is a tall, tubular, in-roll epiglottis. So because the cartilage is very fragile, and they can easily get this shape. And as you see, this is the shape of the epiglottis. So you can well imagine the respiratory obstruction going through it, and it all overlaps the vocal cord also. So what happened? Again, these there's you can see that this is called this specific is omega. Omega, this is presentation, this redhead, and this is the presentation when we will see through the flexible endoscopy. Now, this is the patient, this is the child. Whenever it comes to you, now you can hear the voice of the what is the voice of the laryngomalacia? I hope you have listened it. And this sound will immediately vanish when you put this upside down. And you always tell mothers to do it in your home. How will management in the first of all, you need to reassure the parent that this is this disease would eventually after 2 years would be vanished. So there is no problem in it. But you need to be very careful that the patient should not go into any inflammation, any inflammatory conditions. So because if this omega-shaped epiglottis would be formed in this case of laryngomalacia, then you can well imagine how much respiratory obstruction would occur in these cases. So, the first of all, the diagnosis, the management plan is reassure the patient. Then position change, you need to tell them that you need to put your child in a prone position, but be careful about his mouth. It should be on the lateral side. Otherwise, there could be, respiratory obstruction in those patients with closed mouth. So, but very rarely, in some cases, 1 or 2%, when there is a severe complication occur, then we will go for tracheostomy in severe cases. But ideal, again, the treatment of the surgical treatment in Indonesia is supraglottoplasty is the procedure, is the choice of procedure. And sometimes we can go for these surgical intervention through nowadays lasers, the carbon dioxide laser, microlaryngeal scissors, so that we can cut all these portions and then put it into the and slightly trim it and just remove the excessive cartilage and excessive portion which is obstructing the epiglottis. So now the other condition is called laryngocele. What is laryngocele? Basically, it is an air-filled dilatation of the laryngeal saccule, diverticulum or sac. You can easily see in this case, as you can see. It is mostly seen in those patients who are trumpet players who are doing excessive, when they use their breathing. Like you can see this is the supralaryngocele. Whenever you do the Valsalva maneuver, then this will extend. You can see this will show. Now again, going back to this, there are basically two types, rather three types. First, it is external when it pierces the thyroid membrane, and internal when it remains deep to thyroid cartilage, and combined it possesses both the elements. So in this picture, we can see this is basically an external laryngocele, and sometimes this you can see this is an internal thyroid membrane, and this is a mixed type. When it crosses through it, and then it is appeared in externally. So then what normally again the presentation would be hoarseness, respiratory obstruction. If the size of the laryngocele is increased, then the patient may come with a respiratory obstruction, and of course the apparent swelling in the neck when you will ask the patient to do the Valsalva maneuver or any stiffening exercise, so this swelling would appear. So again, investigate. One of the important things that investigations in all these the congenital anomalies and as well as the larynx, we will go for one of the investigation is indirect laryngoscopy, which we can easily done in our clinics. Then flexible endoscopy, flexible laryngoscopy or endoscopy, it is again done indoor, and we can easily visualize the whole larynx, including the shape of the epiglottis, adiepiglottic folds, false cords, what is the mobility of the vocal cord, and the respiratory, any tumor or mass present, any cyst present over there, any inflammatory changes. So we can visualize without giving general anesthesia to we can examine it in the indoors. Then we will go for the investigations, radiological investigations. Then of course, in all these cases, we will go for X-ray neck, APO lateral view, so we can easily visualize the position of the larynx as well as its relation with the pharynx and all the openings. So in this case, when we will order an X-ray in AP neck, then we will see that there is a air-filled sac present in it. And sometimes we really will definitely go for CT scan when there is internal type of laryngocele. So again, as with every swelling, the treatment would be surgical excision, or if it is present internally, then there is internal endoscopic excision. Marsupialization means when there is a combined form, then we need to excise it externally, and and we will not close it, rather we will staple its edges on lateral side. This is called marsupialization. Now coming to laryngeal webs, this is what, as you can see in this picture, this is basically a vocal cords, two vocal cords. You can see easy this is a web. So what is basically laryngeal web? Failure of complete canalization of the larynx. And this mostly occurs in the glottis and very rarely in the supraglottic regions. And as you can see, this is a part which almost occupies the two vocal cords. So mostly it is congenital type, but it can, but later on it can also occur. The presentation would also occur in the later life. So, what are the clinical features? That, of course, variable degree of it all depends on the size of the web. How the patient would present, either with a respiratory obstruction or dyspnea, which type of strident, respiratory, because there is a difficulty in the inspiration. So the voice, the stridor which would provide, the voice would be weak, high pitched, and squeaky voice would occur in this case. In the case of child, the cry would be weak. And recurrent groups, recurrent infections. Of course, you can see that it is half of the portion of the vocal cord is obstructed. So recurrent upper respiratory tract infection would occur in these cases. So management, if again, in the case of small web, if it's a very small area over here, then what would happen? There's conservative treatment, leave it alone. While in the case of longer web, again we will use either laser therapy. So this normal laser is carbonized CO2 laser, or sometimes we will go for endoscopically dilatation, endoscopically. That is called Bougie dilatation. There is a special instrument which is called Bougie. We will insert under general anesthesia and we will cut all this part of the thread. And something very thick, then we need to keep the endoscopy clean to prevent recurrence. And the longer and thicker with inadequate airway, then of course the presentation in this case is severe respiratory obstruction. We will go for tracheostomy, and then after 3 or 4 years, we will go for laryngo fissure, proper operation for this. But it is only in those cases where the webs are thicker and longer. Now the next condition, which is congenital condition, is subglottic meningioma. As you can see, I hope you must have an idea about the different types of the hemangiomas. One is capillary and the other one is cavernous hemangiomas. So capillary hemangiomas, as we already know, that it is small in its size. It normally occurs in the case of this laryngeal hemangiomas, and of course, initially it is small, but later as the patient grows, then the size of the hemangioma would also enlarges. And for as you can see, if it enlarges and closes the space, then again what would be? It would be life-threatening situation in some of the cases, because the narrowest, it occurs in the narrowest part of the airway. And if it is untreated, then 50% of the mortality will occur. And most of the time, the presentation in this case, capillary hemangioma, mostly the patient would have cavernous hemangiomas in the body as well. So what we will do, again, management would include endoscopy, and we can see this type of shapes of the hemangiomas. And again, management would be that we will go for the management in all cases of the congenital, as the first, if the size is small, then we go for conservative, and then if the size increases, in this case, we will give a try of intralesional steroids and intubation sometimes if it goes more. A larger one, the primary is, of course, excision of the hemangioma, and if it is very large, then tracheostomy, and then wait for spontaneous inhalation, or we will go for surgical resection of the hemangiomas. The next condition is laryngeal and laryngotricus cleft. Cleft, as you can see in this chair. This because this is a larynx and this is your tracheoesophagus. There's a cleft. There's a gap present between these. Now you can well imagine if the larynx and tracheoesophagus clefts are present, and what would happen. So basically, underlying pathology is laryngeal cleft, failure of the posterior thick lamina to fuse. Posteriorly, it is difficult to fuse. So incomplete development of tracheoesophageal septum, sometimes this is another cause of this. Now in this case, there are different types. There are basically 4 types of laryngotracheoesophageal clefts. And type depends on the size of the, type depends on the size of the cleft present. So there are basically 4 types. And the presentation would be according to the size of the cleft. Size of the cleft. Like number 1, type 1, of course, it will occur recurrent cyanotic attacks on feeding. Recurrent, because whenever they will have feed, then it will straight go into the, some of the, it trickle into the trachea, and then immediately coughing starts, cyanotic spells will occur, recurrent chest infection, and sometimes stridor also. Type 2 and 3, if the gap is more, then it's called aspiration, which is life-threatening, and with recurrent pneumonia and stridor abnormal cry of the patient. And type 4, it is a severe aspiration, cyanosis, and incipient cardiorespiratory failure. And in this type 4, there's a high rate of mortality in this case of in these children. Again, management of course depends wholly on the length of the cleft. Short type with no aspiration then requires no treatment. Minimal aspiration cause thickening the fluids, and significant aspiration or very short type to endoscopic repair of cleft in 2 layers. NG feeding आपने करनी है until suture line has healed. And long type 2 and long type 3 approach and clearly why extended laryngofacial with tracheostomy. You need to go, of course, the severity of the, as long as the length of the cleft would increase, same is the case with the management would be aggressive in those cases. Again, type 4, which is the most aggressive type of the cleft, then we will go for, initially we need to, as you know, ABC, that you need to preserve the airway. So we will go for tracheostomy. And there are different approaches, and then of course in the long case we'll go for thoracotomy as well as medium sternotomy. But mortality is 14% overall and 66% type 4. This is the most serious type, and most in this case mortality is very high. Now, another condition is called laryngeal cysts, and this is basically again arises at epiglottic folds. As you can see, this is the cyst, this cyst. These are small, and these are the fluid-filled smooth swelling in the supraglottic larynx. And of course, if it is present over here, then it is not present in the glottic area, but still they can, because the presentation would be respiratory obstruction. Normally, it is as the size is small, then most of the time they are asymptomatic. The kidney enlarges and becomes infected, and the host, stridor, and rapidly increasing airway obstruction will occur. If on flexible endoscopy, you will see that there is of course a bluish lesion in the epiglottic folds. You can see in this case. So again, the treatment would be excision of the cyst. The next condition is vocal cord paralysis. What is, again, this is basically congenital true vocal cord paralysis, and it will occur during trauma to the recurrent initial nerve during birth, or either it is a brief position or possibility, or sometimes they are associated CNS anomalies, sometimes with any syndrome, like as we can see, hydrocephalus, meningocele. So, Down syndrome, these are some conditions in which vocal cord paralysis can occur prenatally. So, whenever postnatally, what would be the presentation? The dyspneic and the stridor in the patient. And when we see, as you can see, this is a normal respiration. And this is the normal respiration, it should be open, the vocal cord, while, abducted position. While in the when we need to phonate, then the vocal cord position is in the case of adducted position. So what happens? You can easily see that one of the vocal cord is paralyzed, flaccid, it is not properly open. So this is the condition, and of course it is basically in the paramedian. It's not in the median, but it's a paramedian position. So if again it depends on the severity. If it is a unilateral paralysis, then we will go for conservative treatment. But if it is a bilateral vocal cord paralysis, then of course we will go for tracheostomy. It's speaking well later on, and then as the patient, when he'll grow up, then we'll go for permanent surgical treatment, that is lateralization of the vocal cord, thyroplasty type 2. You will definitely, get this information in your vocal cord paralysis later on. So we will just lateralize this so that there would not be any respiratory obstruction. Next is basically subglottic stenosis. As the name shows, subglottic stenosis. You can see this is subglottic, and stenos means the narrowing of the subglottic stenosis. So what happened? What is the underlying cause? Basically, it is due to the abnormal thickening of the cricoid cartilage. So symptom, of course, at the size is small. is large enough that for respiration information, their expression would be asymptomatic. But if the size is smaller, then what happens? It would be upper respiratory tract, recurrent upper respiratory tract infection causes dyspnea, stridor, and but in this case, cry is normal because its supraglottis as well as its glottis is normal. So cry would be normal in this case. Again, how can we will go for flexible or the child is small, so we'll go for bronchoscopy and we can see the size of the subglottis. Full term unit, normal size is 4.5 to 5.5 millimeter, but if it is less than 4 millimeter, then there would be the respiratory obstruction. And most of the time, in the case of premature unit, it is less than 3 millimeter. So normally, improves with age, but some they may require surgery. You need to enlarge this hole so that there won't be any respiratory obstruction and there's no problem for the first respiratory obstruction. Now the other thing which we will go today is basically what stridor. Stridor means what is stridor? Stridor is basically noisy respiration due to narrowed air passages. This is, and in all these congenital conditions, we have seen there are different types of, first is obstruction in the supraglottis, glottis or subglottis, and due to this obstruction, there is a specific noisy respiration occurs. So there are three different types of different kinds of noises. So you can easily differentiate between stutter, stridor, and wheezing. So stutter basically it is a snoring, and it basically occurs in the case of yeah, then you're disappointed. While in the case of wheezing, it's a bronchi. Wheezing, whenever wheezing cracks, it will there's a obstruction in the bronchus or lungs. Now, what are the how will you will characterize the problem? Now, first of all, as we see, these congenital anomalies they occur in the children, newborn. So, in this case, and this stridor depends on what is the age of the patient. Either if it is a young newborn child, then of course the first cause would be congenital. While in the case of as a grown-up child, then the cause might be acquired. Then next you will look into that either it is a gradual worsening or severity increases with the time. And what is the severity, mode of the severity? What is the presentation of the child? Either it is a respiratory distress, and of course timing is important. You need to see either this obstruction, respiratory obstruction, cyanosis, or any problem which occurs with the feet, or it is constant, or something transitional, as we have seen in the case of laryngomalacia. So you will go for what is the type of the strider, what is its pitch. You need to identify the site of obstruction, and now then we can find out the different causes of the strider. Now, what are the different types? As you can see in this picture, basically there are three types of the stridor. One is the inspiratory stridor, and there is obstruction in the face and supraglottis. Then the stridor would be inspiratory stridor. While expiratory occurs in the thoracic trachea and bronchi, then this type of stridor is expiratory. And biphasic means mixed type. And it basically occurs in the case of glottis, subglottis, and cervical trachea. So these are the clinical features which can occur along with the stridor. That is cyanotic episodes, voice changes, do you have any reflux or aspiration? These are the clinical presentation of the child. So please, you can. I will. You need to differentiate between these different type of starters, striders, and you can now listen it properly. These are three different type of striders. So what is the underlying principle in it? Basically, the law, which is Poisson's law, that flow which varies inversely with the radius to the fourth power. What does it mean? If there is a opening is normally infant 4 millimeter, but if there is any inflammation or any disease which basically reduce its size, then what would happen? Airway pressure would be the normal, but it would, it's inversely proportional to the fourth power. So there would be a great, respiratory obstruction occur in those cases. Adults, the same goes here. It is but what would happen if anything happens enough space, the patient won't get into the respiratory obstruction immediately. But in the case of they will go into the complication very easily. so, so as the radius is small, then what would happen? Lead to big increase in resistance. Patient would get a lot of effort for respiration. So airway resistance, turbulent flow increases resistance whenever there is a physiology stridor. Either you need to again differentiate it is congenital or acquired congenital. We have gone through all these conditions. And what about the acquired? You need to differentiate either it is afebrile or febrile. Febrile, these febrile conditions, they occur in the case of inflammatory condition, like glottitis, acute laryngitis, laryngotricus bronchitis, and while the afebrile, like patient presentation, either is a child or one of the most common body, either it is a bronchial foreign body, papillomatosis. This is basically due to the cause of these subglottic stimulation, sometimes injury, any laryngeal edema, these adenotonsillar hypertrophy. The condition in the patient presentation is in the case of stridor. Again, I have already gone through all these. These are the conditions that these are, of course, foreign body, epiglottitis, glottis may again foreign body. There would be some trauma. While in the case of subglottic tracheal foreign bodies, and these are chronic conditions which have already gone through all these, and it causes different types of stridor. This is omega shape of the epiglottis. You can see in the laryngomalacia. These are different types of the vocal cord paralysis, normal vocal cord. These are paralysis. And this is, of course, subglottic stenosis. These are different types of, you can see two. These all will cause respiratory obstruction as well as different types of the stridor. It's the foreign body. Most commonest cause in the case of children with the acquired cause of the sinuses and respiratory obstruction. Now, what are the physical findings? Again, when you will see, go through the endoscopy, then what happened? There's a retraction, the cap neck, patient presentation would be distress there. And then, of course, the type of the stridor will give you an idea for what is the anatomic site of obstruction. Like, of course, we have, that inspiratory, and of course, you go to the supraglottic region. Either there's any foreign body present over there, any inflammatory condition. Biphasic, you need to see the mobility of the vocal cord. And expiratory, you will go through the thorough, auscultation, so you will get an idea about the preps as well as the, conditions you can easily pick from there. So again, they are basically, you need to understand, they are obligate nasal breathers, and they have a little bit larger, and larynx is more cranial and anterior. So again, what happened? Any condition, any inflammation, any disease which interferes with airflow, then they will easily get into the respiratory distress and obstruction. Now this is, again, I have already told you, this is basically flexible nasal endoscope. This you can easily, it's an outdoor procedure. This simple flexible endoscope, you can, and you just need a local anesthesia. Put this camera, you can easily visualize the whole, either going through the nose, larynx, oropharynx, then go to the larynx, and mobility of the vocal cord as well as the false vocal cord, any inflammation, any paralysis, arytenoids, movements, everything you can get an idea with a flexible laryngoscopy. And it also definitely gives a very good view to the vocal folds. And the other investigation which we need to get an idea about Malaysia is basically X-rays, both PA view, posterior as well as the lateral view. And sometimes in the case when the anomaly is inside the larynx, then we will go for, and the complication, we are suspecting any complication, then we will go for CT scan. Angiogram, of course, this will give an idea about any vascular malformation. Esophagogram, again, this will give you any laryngotrachobronchial clefts, there is a fistula, there is anything, we can easily pick it from this esophagogram. Now, this is basically a gold standard investigation, as well as, it is basically both diagnostic as well as therapeutic indications of the bronchoscopy. There are two different, you can see. With a direct laryngoscopy, it's an apparatus. It's a small apparatus, and you can but in this case, you need the patient is in the general anesthesia properly, and you need to have proper resuscitation apparatus over there, because where you are putting this laryngoscope and bronchoscope. Where, because in this case, whenever you do bronchoscopy or laryngoscopy, you are not going to put the ETT, and you need to put the larynx. So you have only 1 minute or less than 2 minutes with help of the anesthetist, that he's continuously monitoring oxygen saturation. If it drops, then you need to immediately remove this endoscope, and he needs to resuscitate the patient. But this is an excellent apparatus. You can easily visualize the whole larynx, the position, and everything regarding this larynx, if there is any. But this is a diagnostic, indication of the bronchoscopy. And what about the therapeutic? If there is, any foreign body present in the bronchus, to do the bronchoscopy, and you need to remove it with the help of forceps. But if there is any vocal nodule present in it, if any tumor, so you can either excise it, or secondly you can take the biopsy from it. So they are basically, it is the gold standard procedure, and both patients, and this is basically treatment for them to diagnose as well as give to treat the patients of the with the laryngeal problems. Now, this is again the first treatment stagger. It all depends on the severity of the disease. If it is not very severe, then the treatment would be conservative. And if the patient presentation is acute distress, then definitely we will go for intubation, tracheostomy, leucothyrotomy. These are the immediate and emergency treatment for stridor patient. Now, what is hoarseness? Hoarseness, as we know, any change in the voice is called hoarseness. And the correct definition is roughness of voice resulting from variation in periodicity or intensity of consecutive sound waves. Basically, any change in the voice, then we will label it as hoarseness, right? But and for normal production of the vocal cords, if you see in this picture, normal, you need for proper approximation of the vocal cords, as well as they will properly mobile, and there is nothing and proper size and stiffness is present. Otherwise, the immediate reaction, immediate problem is hoarseness of the voice. And what happens? What are the basically causes? There are multiple causes of the hoarseness, but the one important thing you need to remember: if the patient presentation is with a hoarseness, a change of voice for more than 2 or 3 months, more than 1 month, then it should be properly, examined to exclude the tumor. So again, it depends on the patient. So what happened? Whenever there is the problem is when there is a loss of approximation, like vocal cord paralysis, fixation of the cord, vocal cord tumor, laryngeal tumors, And what size of that cord? It is, acute edema of the cords occurs. Then we would have, there's a possibility of voice, and sometimes there's a tumor, surgical excision, fibrosis, and then the stiffness, of course, decrease in paralysis. They want to stiff and they want to move properly. And in some case, of course, nodule, polyp, anything which is present, anything which is present over here in practice, then there would be a change of the voice. So, how will you investigate? Again, oral history is very important. What is the mode of onset? Duration is very important. How long you will have the patient had this hoarseness of voice? Is it acute? It is constant and it is long lasting. And what is the patient's occupation? And again, its relation with that of your smoking as well. And so, whenever patient comes to us in our clinic, we will go for simple tests like indirect laryngoscopy. It's a very important test, and we can easily diagnose a local cause, either it is a vocal cord nodule, polyp, there's a tumor. We can easily see within that. If we have a flexible endoscope, then it is much more, we will get much more information with the flexible endoscope. Now, rest of examination is again very important because in the most of the cases, in glottic laryngeal cancers, the patient, we need to check the whole, chest X-ray is very needed because if there is any, regional nerve paralysis occurs throughout its course, then we need to find out. We can find it out with the, chest X-rays, CT scans, and sometimes lab investigations for suspected causes also, and direct laryngoscopy. Sometimes again, the gold standard is direct laryngoscopy and microlaryngoscopy for detailed examination of also there is the biopsy and mobility of the cricoretinoid joint. And then we will go bronchoscopy and bronchoscopy and paralytic lesions to exclude any malignancy. The causes, again, the causes are inflammation. One of the most important causes, like acute laryngitis, croup, chronic laryngitis, tumors, papillomas, hemangiomas. In the case of, these are vocal nodule, polyps. These are all very important present in those patients. They are basically abuse and misuse of their voice. Laryngoscopy and trauma, sometimes, direct laryngotricus traumas occurs. It could occur with a foreign body, intubation, laryngeal trauma. So, whenever we intubate the patient in the ICU, we are not going to intubate for more than 10 days. We need to go for respiratory obstruction, tracheostomy, because intubation also will, traumatize the larynx. And then, of course, the most important cause beaten angina paralysis. And if there's any fixation after due to any, arthritis, joint, these are congenital conditions. We have gone through it. And miscellaneous, hysterical hyponia. These are some conditions we are going to voice changes. We will now discuss. One of these dysphonia plica ventricularis. What is ventricular dysphonia? This is basically the voice produced by false cords. This is ventricular folds, and which has taken over. True cords are not functioning properly. So of course, there is change of the voice occurs. And what is the cause? Basically, secondly, to impaired function of true cord, like paralysis, fixation, all the causes which occur. And how will you diagnose? We will diagnose with all those investigations which we have just discussed. And the treatment is difficult to treat because functional type by in most cases the treatment is speech therapy and psychotherapy in those cases. And functional aphonia, hysterical aphonia, this mostly occurs in the case of young females. And again, we can easily, judge in our clinics. When the patient will come, we will ask for a try with cough. If the cough is normal, then it means there's a proper adduction of the vocal cords. So again, in this case, psychotherapy as a reassurance to the patient and to the patient is very important. Pneumonia, again, this is basically mostly like exclusively in the males, and these patients, mostly in the case of boys, those who are emotionally immature and they are very attached to their mothers. And in this, what happens basically? Larynx matures at puberty and vocal cords lengthen. Vocal voice changes. What would be the effect of it? The patient would have lower pitch, low voice, a girlish, change of voice, and this is called puberphonia. So treatment, again, the most important treatment is speech therapy. You need to get proper speech therapist. And there's again one test which we can do in our homes. That is Gutsman pressure test. What it is, basically pressing the thyroid cartilage backwards and downwards, and relaxes basically the stretch cause. And this again, what is the result? That voice is low tone voice produced, and it has got a good prognosis. But the most important thing is speech therapy in this case. Now, again, there's phonostemia. It is mostly patients will come and they see little bit of voice due to fatigue. And this basically occurs in the case of thyroid and intraretinoid weakness of the muscles. And what are underlying causes? Cause is basically voice abuse, voice misuse, and then sometimes it is in the case of smokers and those who are, misuse, misuse their voice. So again, indirect endoscopy, what would happen? Thyroid, if the thyroidetinoid vocalis muscle weakness, then elliptical space between chords. There's a space between chords could occur. If interretinoid weakness, then triangular gap near posterior commissure would occur. And both above muscles and keyhole appearance. There's a keyhole appearance present in between the vocal cords. Again, treatment is voice rest. Another condition that is called hyponasality and hyponasality, basically rhinolalia clausia, and it is basically lack of nasal resonance for words which are resonated in the nasal cavity. For example, MN, NG, it is due to blockage of nose and nasopharynx. While hypernasality basically, this is basically it is seen in excessive nasal resonance and is due to failure of the nasopharynx to be cut off from the oropharynx or abnormal communication between oral and nasal cavity. What are the causes? Hyponasality, we will see in the patient like normal those who have rhinitis, common cold, nasal allergy, adenoids. While in the case of hypernasality, it is basically large nasopharynx, there's a cleft palate, paralysis of soft palate, oroentral fistula. So it's sometimes habitual to some patients. So this is about today's lecture. Now we'll go through few questions. If you are able to answer it, then it would be good that you have listened to lecture. So the first question is, and you can answer it in your chat. What is the most common cause of stridor infection? Either it is a vocal cord paralysis, subglottic stenosis, hemangioma, or laryngomalacia. As we have, I think, gone through it, and we have most commonest cause of stridor in infants is basically laryngomalacia. The other questions, these are the most important questions. They could occur in your prop and exams. The case presentation is a male newborn attend ENT department at Avicenna Hospital having stridor which used to increase on crying, but subsided on placing the baby in prone position. Thigh was normal. Parents were worried and wanted to have immediate ENT opinion. What is the diagnosis? Findings and treatment. Proper laryngoscopic finding, you need to write it down over here. And diagnosis, of course, you must have an idea that is this here. Laryngomalacia. What are the laryngospecific findings? Specific epiglottis and treatment. Mostly conservative treatment, but in the case of few cases, we will go to for some aggressive treatment, surgical treatment as well. The other scenario is a 40-year-old trumpet player attended ENT department at Avicenna Medical Hospital, having hoarseness for last 3 years. He is having reducible swelling in the neck, near angle of mandible, which increases on coughing. So again, what is the diagnosis? Diagnosis is basically laryngectomy and all the investigations. And what is the management? Of course, the surgical, depending on the size, and mostly management is surgical. Hope you understand the lecture, but if you have any query, please write it down in the chat box so I can answer you. If you have any question.